Now let's go over AV Reentrant Tachycardia, or WPW, which stands for Wolff-Parkinson-White syndrome. This condition can cause fast heart rhythms, can make people have palpitations or pass out, and it's a pretty common thing. You can see it on ECG, so it's an important thing to learn, and it's tested pretty frequently. First thing I'd like to start with is the main hallmark of this is the delta wave on the ECG. And the delta wave comes from conduction through a bypass tract that goes from the atria, one of the atria, into the ventricle, directly bypassing the AV node, which is here. So the bypass tracts can be on the left side, or they can be on the right side, or they can be septal. In this example, I made it on the left side, from the left atrium into the lateral left ventricle. So what happens is the sinus node over here depolarizes. Conduction goes through the atria, and normally it would go through the AV node, and then the His bundle, and then the bundles, and set off a normal QRS. But with WPW, the conduction gets over here to the bypass tract, and unlike the AV node, the bypass tract doesn't slow down conduction, so it goes straight through there and gets into the ventricle, and the ventricle starts depolarizing sooner than it would normally. So you end up, instead of seeing a flat PR interval like you would if it was a normal situation, you'd see a flat PR interval, and then the QRS would suddenly start. In WPW, you see the P wave, and then right here, conduction through the bypass tract happens, the ventricle starts to depolarize, but it's not using the His-Purkinje system. It's outside of the bundles, the left and right bundles. So that means that depolarization happens slower, which is why it's a kind of a slur and not as sharp as a normal QRS. So that's going on. At the same time, the AV node is delaying things, as it always does, and then all of a sudden the His-Purkinje system depolarizes here, and then the bundle branches depolarize, and that's when the normal QRS starts. And that happens. So you've got the delta wave, which is that part right there, the slurred QRS. Let's take a look at an ECG with sinus rhythm with the delta wave. This also shows the other hallmark, which is a short PR interval, which is defined as less than 0.12 seconds, or less than 3 little boxes. So we'll start with this over here. There's a P wave here in V4, a P wave, a delta wave, and then the QRS. And here, P wave, delta wave, QRS. The delta wave doesn't always have to be up sloping. It could be down sloping, and here in AVL that shows that. Delta wave is here. This part right here. So there's a P wave, can't see it very well, but then the delta wave happens, and then the QRS. And over here, it's color-coded, P wave, delta wave, QRS. So that's an example of sinus rhythm with the delta wave. Now, when patients are in sinus rhythm, they don't have any symptoms, but the WPW can be a setup for fast, regular heart rhythms, which give people symptoms. So here, I'm going to show you the schematic for that. It gets triggered typically by a PAC or PVC. This is called orthodromic WPW. Ortho means straight, dromic means traveling, so it means it travels straight, and what that's referring to is the conduction is traveling straight through the normal pathway for conduction, which would be AV node, His bundle, and then the left and right bundles. The problem with AVRT, though, is that when the contraction wave gets over here to where the bypass tract is, there's backwards conduction through it. And that's not supposed to happen. And that results in the atria depolarizing backwards, like that. And once that depolarization wave hits the AV node, the whole thing starts all over again. So then the His-Purkinje system goes, then the bypass tract and the atria, and around and around. So it goes a lot faster than it normally would. Let's look at an example down here. So orthodromic AVRT. It's fast, it's narrow, it's regular, and you see retrograde P waves typically happening right after the QRS. It doesn't have to be immediately after the QRS, but it's typically pretty close to the QRS, and sometimes it's even buried within the QRS. Let's look at lead 5. There's a QRS, upside down P wave right here, T wave, there's a PR interval. Actually, the PR interval starts over here and goes to here. PR interval, QRS, P wave, that's lead 5. And over in lead 3, I show it color-coded. There's a QRS, there's retrograde conduction through the
Bypass Tract.
There's an upside down P wave, kind of there. Then there's a PR interval, another QRS, retrograde through the
Bypass Tract.
upside down P wave, and another PR interval. So there you go, that's orthodromic AVRT. Now for AV nodal reentrant tachycardia. It's pretty similar to AVRT, except the bypass tract is basically within the AV node. And the AV node has oftentimes two pathways, a slow pathway and a fast pathway. I don't want to get into that too much, but the bottom line is within the AV node, things can go backwards sometimes, the conduction can, and that can cause problems. The symptoms are very similar to AVRT, basically they're the same. Fast palpitations, passing out, exertional intolerance, typical cardiac arrhythmia symptoms. So AVNRT looks a lot like AVRT. It's fast and narrow and regular, and there's a retrograde P wave, oftentimes right after the QRS, or sometimes within the QRS itself. Here's a little schematic over here. So this is also oftentimes triggered by a PAC or PVC, and conduction goes down the AV node, into the His bundle, and then into the left and right bundles. But at the same time, it's also going backwards in the AV node, and then the atria depolarize upside down, and it ends up going again back through the AV node. So the circular part of the rhythm is happening here, and you end up getting a fast, regular heart rhythm. Let's look at an example right here. So there's a QRS here in V6, QRS, an upside down P wave right at the end of the QRS T wave, PR interval, and then another QRS, upside down P wave. And it's similar in lead 2, same type of thing. And you've got this upside down P wave happening right after the QRS. Sometimes it's more visible in AVR. People like to look at AVR, and if you see a little positive P wave in AVR, that implies AV nodal reentrant tachycardia, because usually the P wave's negative in AVR. Really, this looks very similar to orthodromic AVRT, which we just talked about. Let's do some more ventricular arrhythmias. We learned about PVCs in level 1. Now we're going to talk about non-sustained ventricular tachycardia. That's defined as 3 or more beats. It's got to be less than 30 seconds, and it should be greater than 100 beats per minute. And that's when basically there's multiple PVCs happening one after the next. And its origin is the same as a PVC. There'll be a spot in the ventricle that goes off and takes over the heart rhythm. And you've got a nice narrow complex here, but then a wide one and another wide one with T waves going the opposite direction of the QRS. This is a PVC couplet because there's 2 of them. Here's another PVC couplet. Here is the non-sustained ventricular tachycardia, where you've got 5 beats, 1, 2, 3, 4, 5. These will often have a retrograde P wave. That's a really good clue that you're dealing with a ventricular beat, and that's probably what this is right here. Take my word for it. Right there. All right, let's move on to sustained ventricular tachycardia, and it's pretty straightforward. It's greater than 100 beats per minute and greater than 30 seconds. So you can see this is fast, it's wide, and it continues. You look for retrograde P waves, which aren't particularly evident in this ECG. Perhaps this is right there, a retrograde P wave. And maybe there's one here, but it's impossible to say that for sure. Here's an example of supraventricular tachycardia with left bundle branch block. So it's got combined problems with the left bundle branch block and a fast rhythm. And this comes up pretty commonly because it's wide, as you can see, wide complexes, and they're happening fast. So it looks a lot like the ventricular tachycardia I just showed you. But this is actually an example of supraventricular tachycardia with aberrancy. And that just means that the rhythm comes from the top chambers of the heart, and then there's a wide complex. That's what the aberrancy means. So let's go through this one. Atrial flutter 2-to-1 conduction. So we see it's fast, we see it's wide. I'm going to teach you about the Brugada criteria in level 3. But for now, we've got a fast rhythm, we've got a wide rhythm, and there are P waves happening at a regular interval of about 300 beats per minute. And it's kind of hard to see them in lead 2. It's a little easier, I think, to see some of the P waves in V1 up here. I clearly see this P wave and this one and this one. I don't see the other ones as well. They would be happening right in the middle between those two. And it's just a little bit visible there. And the intervening P waves that are happening at the end of the QRS are more visible in lead 2 down here. So there's atrial flutter. And then as we learned in level 1, there's a left bundle pattern where it just goes up. There can be a little notch, like there is here. It's a R wave in lead 1. And then with a large S wave in V1 here. And then these QRS complexes are happening every other beat, so it's 2-to-1 conduction. This is an example of how you can have a fast, wide rhythm that's not actually ventricular tachycardia, but rather supraventricular tachycardia. All right, let's look at this one, which is supraventricular tachycardia with a non-specific intraventricular conduction delay, which I'll talk about more later. But this just means it's a wide complex, greater than 0.12 seconds, but it's not a right bundle or a left bundle. And when you're looking at this, basically you've got to really look at the morphology of the QRS during the tachycardia and compare that to the QRS morphology in the normal sinus beats. So over here, this is the start of the tracing. There's a P wave, then there's a QRS, a T wave, another P wave, QRS, etc. And that goes along. And then all of a sudden, there's this portion which is tachycardic. It speeds up. There's a P wave, then there's a QRS, and the morphology of this QRS is the same as the preceding one, which was a sinus beat, T wave, and then there's a QRS, couldn't see any P wave, T wave, QRS. And each of these QRSs looks the same as the QRS looked over here in lead 2. You can see the same thing here in lead V1. There's a QRS, and then the QRSs start happening without the P waves. And if you compare these QRSs to these over here, which are from sinus, they're the same. So the morphology in this part is the same as when it's sinus, and that means you're dealing with a supraventricular rhythm, that it's not coming from the ventricles, that this is not VT. This is SVT. It's coming from the top chambers. So that's an example of SVT with nonspecific IVCD. I get that consult a lot when people look at telemetry and you see this here. They see it's fast and wide, and they say, oh, the patient's had VT, and they consult me. So you'll know not to consult the cardiologist when you see that. You'll know that's a brief episode of SVT, which is of less clinical import. All right, here's an example of SVT. It's not VT. This is atrial fibrillation with right bundle branch block. So this is wide. It's not super wide, but it is wide. It's one of the phases of right bundle you learned about before. That's about 0.12 seconds. And it's irregular, so the QRS complexes are not happening at regular intervals. And when you see fast and irregular, probably the most common thing is atrial fibrillation. So we're going to look for P waves. I don't really see any P waves anywhere. The closest thing might be this little wiggle over here, but that's a T wave. So we don't see P waves. It's irregular. It's fast. We're talking about atrial fibrillation. And then it's wide because there's a right bundle branch block present. So this is definitely not VT. This is going to be an SVT. And this is a common scenario. It comes up a lot where somebody with a right bundle or a left bundle has atrial fibrillation, so they get a fast, wide heart rhythm. A couple more things here at the end for rhythm. Torsade de pointe, which means twisting of the points, which just means that the ECG looks like there's something twisting. This is synonymous with polymorphic VT. I like polymorphic VT because it really describes better what's happening. So there are multiple morphologies of the QRSs. And you can see that here, that the shapes of these QRSs are different. Like these ones are clearly different from this one, different from that. But I can see what they're saying. It looks kind of like things are twisting with polymorphic VT. So the rate for that's usually in the 200 to 280 beat per minute range, and it's got a sinusoidal appearance, so it looks like this is happening if you do a profile of the QRSs, and it's oftentimes preceded by a long QT interval, with the QT interval being, this is an example of a QT interval where the QT interval starts with the QRS. This is all part of the QT interval, and then there's the T wave. So that would be a QT interval. And the granddaddy of them all, the ventricular fibrillation. So that's irregular, chaotic electrical activity without a distinct shape, and it's just wiggling. That's ventricular fibrillation.